So today we're going to just briefly review some of the newer agents that are now in clinical trials in lupus, discuss interim results, and talk about really the pathways that we're learning more about and hoping to co-opt for therapeutic benefits. And I just would want to put it all into context if I can. And I have to say that lupus is a clinical syndrome. I think it is actually one of the most difficult and challenging topics to present to medical students, which is actually why I always volunteer to give those talks, the introductory talks, because truthfully, as we all know, superficially it makes no sense at all, and that it's really more like a Chinese menu. But if you see a patient in the exam room, I really think that often there are features and you can just get the gestalt from across the room. And I can see some of these molecules, truthfully, that are dysregulated. So in this schematic that was published by Ann Davidson a couple of years ago, it just has some of the salient points, the most important points. And so the point is that lupus, the most prominent signatures really relate to B cells, and 98+% of patients will have positive anti-nuclear antibodies. We think that these are most often affecting the patient as immune complexes, and we're not so certain that the actual antibody binding site is directly toxic. But if we look at the immune complexes coming off of this plasma cell, they have a very particular sets of specificities related to binding to DNA or to apoptotic cells. And the idea is that we think that these are part of the self-perpetuating pro-inflammatory process itself, and that cells that have Fc gamma receptors will take them up and deliver their payload to what would otherwise be sites sequestered deep within the cell. Toll-like receptors, and particularly TLR7 seems to be very important. And so something that shouldn't be able to get inside and stimulate through this innate receptor does, and the outcome, if it affects a plasmacytoid dendritic cell, will be type 1 interferon, and downstream of that, other cells, and here we have a myeloid dendritic cell, can make other inflammatory factors like BAFF and IL-6. And so those can then amplify the process by affecting cells that include B cells, and B cells will be stimulated directly by BAFF and TLR's activation, and this may actually enable the survival, proliferation, and differentiation of autoreactive cells that otherwise would be deleted. And so that will result again here in differentiation of plasma cells, and the whole process drives on and on and on, is very difficult to interrupt. So with those factors involved in this simple schematic, there's a new agent called Supramol. That's the brand name they're proposing, and it's SM101. And it really is a very simple formulation. It's just a recombinant soluble Fc receptor. And the idea is if we can flood enough of these molecules into the body, they should be able to bind and soak up all of the immune complexes and block them from interacting with the Fc gamma receptors that are membrane associated. So that should stop these immune complexes from driving the inflammatory process. And so in a very small initial phase 2A trial, 51 patients with very active disease, a SLEDAI of 6, relatively active, were treated, and it was just a very brief trial with weekly infusions for 4 weeks. And you can see that amongst these 51 patients, they did see a difference between that and the placebo-treated group. And they thought that this is very hopeful for the future. Of course, we must spin our data and be as positive as possible. And here they thought patients that had evidence of lupus nephritis had even better responses, although, of course, the numbers are always much too small to be impressive. And so we're considering whether or not this may be attractive enough to go into phase 3 trials. And the effect here is really very similar to the level of efficacy seen in belimumab, which of course was the first agent approved for lupus based on randomized controlled trials. So I think this was already alluded to by John Kay. I think this agent Sifalimumab, which is an antibody to type 1 interferon, a lot of evidence correlating higher levels of interferon, but really more specifically an interferon signature that cells may well have been stimulated in vivo by type 1 interferon. And so the question is whether or not we can infuse enough antibodies to actually soak up and block that pathway to provide clinical benefits. And so here they looked at several different doses, 200, 600, and 1,200 milligrams IV, patients who were treated for a year, and they tried to analyze their data from different perspectives using different variations of combined SLE responder indices that required either improvements of 4 points in the SLEDAI scale or 6 or 8, and basically they didn't really see much of a dose response. So there's really a minimal effect with the lowest dose, and they really don't see greater and greater doses or effects with greater dose usage. And I have to say that, of course, this always reminds me of my wife, I have to say, because she would look at this and she's really just the terminal optimist. And she'd say, well, this is very hopeful. If they could refine the dose or give a bigger dose, it would be great. And I have a very different concept. It's not that my glass is half empty, it's just I can't find my glass. I don't know where it is. So I actually find this very unimpressive, very unimpressive. So certain agents never die. They just keep getting analyzed retrospectively in an ad hoc fashion. And this Atacicept was really, I thought, one of the most appealing concepts conceptually. It's a soluble receptor that was actually cloned and put with a Fc constant region. We were discussing this briefly yesterday, the whole notion to increase half-life, and it actually can soak up both B-cell activating factor, also called BLyS, as well as APRIL, two very related molecules related to B-cell survival and activation in the immune system. And when they went through a trial and they actually had questionable efficacy and they had to terminate it actually because of severe infections in some of the patients, they went back and they looked and they wondered whether or not they could eke out some evidence, something to be hopeful about. And in fact, they decided that patients that had higher levels of the Atacicept in vivo looked like they had a reduced flare rate. So I don't know whether that's really compelling enough to go on further. It is kind of intriguing to think that belimumab, an antibody just to one of the two molecules, was significant enough to provide clinical benefits to be approved, something that looks like it should be more powerful and interrupt two circuits that are related. Actually, you just have to keep turning around the data till you see something that's hopeful. But I wonder whether or not these trials will actually end soon. So IL-6, Stefan told us all about IL-6 and actually the different perspectives on cis and trans signaling. So Pfizer put together a molecule which is new and improved and better and more potent. It does not actually target the IL-6 receptor like tocilizumab, but it in fact just directly binds IL-6. And it has very high affinity. It has a lot of attractive properties. So in a phase 2b trial, they looked at the effects in lupus. And they really thought that it should be biologically more active. They looked at 183 patients, and again, they really saw very limited efficacy, and the part that's quite odd is that there is clearly no dose response benefit. The higher dose, they actually had to stop because of adverse events, and so here you might again think that your glass is half full. You can see some benefits using this alternate responder index. But in fact, I think it's really a very confused topic, and it makes you wonder whether or not IL-6 targeting is going to be helpful if you look at unfractionated lupus patients, although there might still be some subset that it might benefit, but we don't know enough, I would say, to figure out who those patients really are. So from some perspectives, some encouraging results with these agents. Efficacy, at least for the Fc receptor that was infused, was really comparable to belimumab. I think there's a lot of ambiguity about what clinical endpoints we should be using, and the question really is the problem with the agents, is the problem with the pathways, or really does it have to do with how we're measuring clinical benefits? Let me just switch gears a little bit to some other agents, and repurposing agents I think is something that provides a lot of opportunities, and Peter was talking about that in great depth yesterday. So I have to say that multiple myeloma is a disease that really responded to absolutely nothing. It just was such a horrible condition, and someone really thought of something as a new approach that really has been remarkable and provided benefits for many patients, and it's these proteasome inhibitors. And I'm going to actually just switch to this picture, which I think better illustrates it. And the idea is that when cells are active protein producers, and every cell needs to not only produce and fold proteins properly, but some of them don't actually work out, and so they misfold, and you need a way of getting rid of them because otherwise they can interfere with other cellular processes. And so there's a structure, an organelle called a proteasome, And when proteins don't fold correctly, they're ubiquinated, and they go right into the dumpster, go right into the garbage disposal of the cell, the proteasome, and that actually keeps everything running, and then you can recycle your proteins. Plasma cells are fantastic protein producers, and they're running at maximum levels all of the time. And if any of their proteins are misfolded, which occurs quite frequently, they can really be very toxic. And what this does is interfere with the, again, degradation system. So these, particularly plasma cells, are very, very susceptible to the effect of proteasome inhibitors. When you have a monoclonal population that's malignant, this can be very, very effective, and it's been used extensively. Bortezomib, which was the first agent of this class that was approved, has some nasty toxicities, including peripheral neuropathy. But they actually say that it is really the heavy metal that's involved in this particular agent in the bortezomib. What is it, beryllium? Boron, excuse me. I knew I'd be corrected. That actually contributes to that peripheral neuropathy. So there are second and third agents that have been introduced. Second has been approved. Doesn't seem to have the same level of toxicity. And so can this be repurposed, particularly for diseases like lupus, in which there's high levels of autoantibody production? And so from several years ago, Jen Analyck's group at University of Rochester described the efficacy potentially in 2 different mouse models of lupus that really are driven in different manners. And they actually showed that proteinuria here in the solid figures was greatly improved, both in this MRL-LPR model as well as NZB, NZW. And in fact, you can see the effects on the kidneys, that the proliferative lesions actually were greatly improved. And so this is very, and IgG levels, and to some extent the autoantibody levels were reduced. So in Germany, they can do very aggressive studies, apparently. They had an open label study where they treated 8 lupus patients that were very active, and they gave them 4 21-day cycles. And they found, in fact, really remarkable effects. The average SLE went down from 13 to 4. Double-stranded DNA antibodies greatly reduced, and preferentially compared to anti-tetanus antibodies. And in fact, other markers to suggest that the immune system was normalizing were found, so complement levels actually improved, and BAFF levels also seemed to go up, suggesting there may be effect broadly across B cells. And this is actually recently published data. Here you can see the SLE in these very different patients. In general, went down, and every patient had some level of benefit. And if you look over here, that proteinuria also reduced. So in general, this seemed to be an attractive trial. The question is what patients you treat and what kind of regimen, because there may be, I think, over long periods of time, very immunosuppressive effects, because it really can broadly affect antibody production. Just briefly, PI3 kinase relates to G-linked protein receptors in the cell membrane, and really is at the interface of a number of different pathways involved in cytokine signaling as well as B-cell receptor signaling. And so the latest agents have now been, they've been looked at actually in cancer to start out, and agents that, there's an agent that interferes with PI3 kinase, and then the related pathway, the BTK kinase, that's involved more specifically in B-cell receptor and FC receptor signaling. And the question is whether or not this will really be relevant to lupus as well. And once a drug is approved for another indication, and CLL actually was approved for, it's only a matter of time until there's some trials and other indications. I just did a quick review of FDA.gov and look at a number of other agents that are being examined or repurposed. So rituximab with cyclophosphamide and then belimumab, an interesting combination in lupus nephritis. That study is enrolling. Other approach that was developed for the treatment of kidney transplant rejection with Rituxan and MMF. This Rituximab is also being looked at. And so we may be hearing more about B-cell targeted therapy in lupus patients on the horizon. Just to go back to a topic that I mentioned yesterday, a third-generation anti-CD20. This OBI, which used to be called GA101, is approved for the treatment of CLL, and this actually has very deep B-cell depletion in the tissues, not just in the blood, and whether or not that'll provide clinical opportunities that's still being discussed. All right, so we went through a number of topics. In general, we have encouraging results about several of the agents. I actually think the SM101, also called Supramol, I think may be encouraging. It seems to actually be a very safe agent, and it's sort of a novel pathway to think about interfering with immune complex pathogenesis. I think the interferon blockers are still a big question, and a number of other things are being examined. We may actually resurrect either rituximab or third-generation agents. So much to learn about lupus, but there are new opportunities. All right, thank you.